patient may, if we give amiodarone to the WP
amiodarone changed to class 3. Actually,
yeah.
When I fellows, I used the amiodarone. I loved it, but they changed to 3.
I mean, when we saw the first EKG, I think I would try the adenosine, and in that patient had the pre-excitation. I just wonder how many chances that he may have the VP or the unstable outcome.
Not that significantly high. Do you know the mechanism? Maybe know the blocker.
Yeah, it
precipitated the VF in patient with syndrome.
I guess that adenosine has a tendency to make the AFib, and the AFib goes to the Kutter pathway and make the VFib. And I guess that the chance is very low.
But it happens. But it happens, yeah. Because the AV node conduction and accessory pathway conduction, they're interfere feature. Yeah. So that is so-called electrotonic conduction. But if you block the AV node conduction by adenosine patching filter, the accessory pathway anterior conduction is precipitated. And if it is atrial fibrillation, you made atrial fibrillation, it can convert to ventricular fibrillation. Okay, so record the question.
Good morning, everyone. My name is Park Dok, EP Fellow with Johnson Children's Hospital. I will present the case for the EGM conference. This is a 22-year-old female. She presents with the complaints of palpitation, which the patient having experienced last few years, and maximum duration was 40 minutes, and are characterized by sudden onset, and she has no past medical history. And documented ECG shows narrow QRS complex tachycardia, and this is 12-lead ECG and normal sinus rhythm. And chest X-ray shows no cardiomegaly, and transthoracic echocardiography reveals normal-sized cardiac chambers, and ejection fraction is 66%, and diastolic function is normal, and treadmill test was negative. Now, I would like to present the electrophysiological study. This is initial catheter position. Two quadripolar catheter was placed at RV and his area respectively, and duodenal polar catheter was placed with RA and coronary sinus. And basic rhythm was sinus rhythm, and cycle length was 991. AH interval 69 milliseconds, HP interval 43, QRS duration was 63 milliseconds. And during the RVP 600 milliseconds, the earliest atrial activation was recorded at HIS 1-2. And VA block cycle length was observed during RVP 280 milliseconds. And VA decremental property observed during single ventricular extra stimulus. And VA conduction system ERP was observed during single ventricular extra stimulus. And VERP was noted by single ventricular extra stimulus 600 and 220 milliseconds. After that, we started atrial overdrive pacing, and AV block cycle length was observed during RAP 320 milliseconds. And AH jump was observed during single atrial extra stimulus. And also single echo beat was observed during 600 and 380 milliseconds. And AERP was observed.
Come on. I'm sorry. Could you please slow down? Yeah. Let's give audience to the.
Okay.
Yeah.
This is AH jump. And also single echo beat was observed. And AERP was observed during single lateral extra stimulus 600 and 200 milliseconds. And narrow QRS tachycardia was induced during single lateral extra stimulus 600 and 300 milliseconds. And tachycardia cycle length was 356 milliseconds, AH interval 204 milliseconds, and HV interval 52 milliseconds, and QRS duration 76 milliseconds. And we reset negative, didn't advance the following A signal. And entrainment pacing at RV apex exhibited PPI minus tachycardia cycle length 263 milliseconds. And after that, I measured, we performed PAC delivered at different phases of the tachycardia cycle in order to EV and NRT distinguish from junctional tachycardia. And first one is we evaluated response to earlier PAC. And second one is evaluated response to his refractoriness PAC. And first PAC is introduced before junctional rhythm, junctional depolarization. In this case, response occurred advancement of the immediate His signal and termination tachycardia. It means PAC advanced the His by activation of the AV node fast pathway. And however, that makes the fast pathway refractory and unavailable for retrograde conduction, so terminating the AV and RT circuit. If it is junctional tachycardia, it must be ongoing the tachycardia. And after that, a PAC introduced during His refractoriness and advancement of next His signal after the PAC means anterograde conduction via slow AV nodal pathway, and this is excluding the diagnosis of junctional tachycardia. And also delta HA interval was measured during pacing HA minus tachycardia HA and less than 0 milliseconds. And in summary, the earliest during RVP His 1-2 concentric atrial activation and VA decremental property and narrow QRS tachycardia was induced single lateral extra stimulus and OVR8 PPI minus tachycardia cycle length over the 115 milliseconds and AH jump and single echo beat. And response to PACs during His refractoriness, advancement of next His, and response to earlier PAC, advancement of the immediate His with the termination tachycardia, and delta HA interval less than 0 milliseconds, and with impression typical EVNRT. And this is ablation catheter position. This is pre-ablation signal during normal sinus rhythm. We can see the slow pathway potential. And this is pre-ablation signal during RAP, 500 milliseconds. And during the radiofrequency ablation, we observed junctional rhythm. And after that, the successful RF ablation of slow pathway and tachycardia didn't induce the programmed extra stimulus. And this is after the RF EGM, and this is 12 VTC.
Okay, thank you very much. And the question from faculties. Can I see the entrainment pacing? I'm not sure it was the proper entrainment or not. So last 3 beats, VA linking. Is there VA link? Maybe not, right? Mm-hmm. So it was not a proper entrainment. Mm-hmm. Okay. And the ablation, can I see the ablation signal immediately before? Yeah, previous one. You told this is a slow pathway potential, yeah, but the slow pathway potential is a little later than the His signal. Mm. Does it make sense?
Yes.
Yes? Slow pathway should be close to the part of AV node. Yeah. His is away later than the AV node. So is it possible? But you burnt it burnt there, right? Okay, Dr. Huang, are you there?
I am here.
Please comment to
Okay.
this case.
Do you have a 12-lead ECG of tachycardia?
Okay, let's start
Okay,
from
can you show 12-lead ECG of tachycardia? Okay. And how about sinus rhythm? ECG. Okay. Now go back to the tachycardia. Is there any difference? You see? Tell me if you the tachycardia and the sinus rhythm. Lead 3. Wider a little bit. Right? Yeah, go back to the sinus. Yes. And the all this 12 lead need to be watched carefully. Okay, patient has the right bundle branch block and tachycardia, a little bit more. X is, I think, is pretty close, but may not be the exact the same. Okay, so you don't see P wave, retrograde P wave here, or do you see it? And lead 2, there's a retrograde P wave, right? Tachycardia, small hump, right after the QRS. Yeah. Okay, so it's a very short RP tachycardia, very fast. Okay, it's going down. Okay, keep going. Okay, keep going. So base, show me the heart, just chest X-ray a little bit, please. It's very slender, long, thin chest. Okay, it's good. Okay, next. Basement that you had initially. Okay, go. So I know his bundle catheter shows pointing upward, far distance away from the CS catheter, an X-ray. Look at the chest X-ray. Yes, your CS 5-6 and his distance is quite big, quite long. Again, your IV catheter in the high septum. For SPT cases, probably it's not a good idea to put a IV catheter in the septum. We talked about that last time. Try to put a apical or a little more toward the base, so it can give you better differential diagnosis. Okay? All right, let's go. Let's get the baseline ECG. Baseline intracardiac signal, please. Okay, good. So, what do you think about this EKG? His bundle, is it good enough? This is proximal or distal his bundle you're recording? You think? It's probably proximal his bundle you're recording because your his is not single sharp potential. Okay? A reasonable, but proximal all 3, 4, 2 has often. Okay, going down, keep going. Pace, you do the EP study, Pagma. Go ahead, please. Advance the slide. Okay, that's a VA conduction. Now, what is unusual? Don't stay there. Go back. You went through this very fast. Pacing, VA conduction. What is the earliest? The baseline pacing. Yeah, CS, first the extra stimulus. Your CS moved out. I cannot see subtle A, but a subtle A looks like earlier than CS, this one. Next one. What happened? You think that there's a jump, right? Your subtle A moved out. CS 5-6 is earliest, right? So there's a posterior activation here. Okay, keep going. Keep going. Okay. So this block, keep going. Okay. Here. Watch this. No, stop there. Right there. Don't move. So what happened here? Your A pacing, what did it do? Look at the your third capture bit. First capture, okay? And second capture, third did what? Do you think with that A I'm talking, that's a capture bit or that's actually some sort of a echo bit? That did not conduct anyway. And then your third one didn't, I don't know whether capture or not. There's a capture. And then that echo bit, I think this last bit that you see, one-to-one conduction, could it be capture bit or could it be a fusion bit in tachycardia? Hard to know, okay? Because you having Wenckebach cycle, suddenly start conducting one-to-one. You see that last four complex. Every pacing has a 1A. Before that, you had AB linking was broken. Now you got AB linking here. So maybe there's already tachycardia. It's hard to know. You're pacing too fast. Okay, let's go. Keep going. But CS56 is earliest. Just keep an eye on it. Okay, keep going. Okay, keep going. So keep going. Yes. First echo beat. You had the echo beat right there. It is normal to see CSA before the local V. CS56, 7, 8. They are before the local V. Preceded. Your V is behind. Right? The sharp is A. Broad is V. V activation is later than A activation. So what I'm trying to tell you, if this was a tachycardia, CS exit would be this slow pathway exit, right? Then going to the fast pathway, coming down again. So this is the tachycardia antegrated exit site inside the CS. Make sense? Then from there, you're going to the slow pathway, up, orthodromic, go to the AV node, go down to the His bundle, the other one, turn out the fast pathway. So this is a normal you see in AVNRT. That's what I'm asking you. Have you seen this before? Anyone has a comment about this? It looks like a silent. Can you guys hear me?
선생님이 뭐라 그러신지를 지금 잘 못 알아들었습니다.
Okay.
왜냐면
So
마이크가 지금 자꾸 중간중간에 끊겨요.
yeah, if you have AVNRT, can your local activation, A activation, can come before the local V? CS56, A7, 8, your A preceding local V. That's a P, that's a A, and the next is a V. Am I right?
Yes.
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 So when would that happen? That's what I'm asking.
I saw that phenomenon from time to time during AV node ablation.
Yes.
But last time you told me that we need to think about the nodoventricular possibility of nodoventricular.
Yes.
But not always.
Not always.
That's
Yes.
why I tried too many pacing maneuvers for this patient.
Uh-huh.
But honestly, this case was
Yes,
yesterday
please.
first case, right? At the time, my eye condition was very bad, so
Okay.
sorry to my patient. We burned over 10 times, right?
Yeah.
11 or 12 times, yeah.
Okay.
So the activation sequence changed little by little, and also during ablation, had induced again and again. So I had a hard time. Yeah,
Yeah.
please tell us
Yeah.
what does it mean? The retrograde A activation is earlier than V.
Yes. So we think there is, unusual form of a closed law. It's very short, sort of, if you will, leftward posterior extension. And then they can come out through the septum very quickly. And if you notice that your CS catheter, 5-6, is, I think it's just barely inside the CS os, roof of CS, close, I would say. So if you look at the actually earliest, A is in 7 and 8, and then 5, 6 after that. Yeah, I think that front guy, that sharp guy, earlier than 7, 5, 6. I wasn't in the case, I cannot tell you. But next one, next bit, you can see your 7, 8 is a R, not the Q, P wave. Next bit, yeah, the small guy, yeah, that guy before. First guy is a A, second guy is a V. Okay. So this patient might have a very fast activating downstroke leftward extension, unless patient has a node ventricular. But I don't think it's node ventricular because of your HCV interval. When you advance, when you give extra stimulus from the CS5-6 where the exit site, your His bundle advanced, right? Am I right? That's what you said. Go to that CS extra validation. Show me. That's what I saw. Maybe I'm wrong.
Dr.
Please.
Wang, I
Yes.
saw this kind of activation sequence in patient with the his bundle recording area and the coronary sinus the separate far away. Like
Yes,
this
that's
patient,
correct.
especially
Yeah,
the vertical
yes,
heart position.
yes, vertical height. Yes, that's what I'm understanding because pathway coming straight down from the septum. I think that's what it is. But anyway, go to the CS extra you gave differential diagnosis. Show me, and then you measured his bundle there. Yeah, right there. No, no, don't go anywhere. Right there. It's not before that. This one. You paste a CS5-6.
Whoa.
This HRA. Yeah, there we go. Leave there. Yes, leave there. Okay. Now, if you look at clearly your his bundle activation timing during the tachycardia, did you measure HH here? HH got shorter with a this. So HH, and then that got shorter. It got
Yeah.
yeah. So this is evidence that is not a node ventricular pathway. Okay, because the node ventricular pathway, atrium is not a part of a tachycardia circuit. So CS pacing would not do anything. Okay. And this proves that that CS5-6 you paste, or 7 and 8, whichever, probably close the exit site of anterior limb of a slow pathway. That's what the Sonny Jackman does to prove that the AVNRT by advancing his 10 millisecond or so earlier than his bundle, they can advance it. Now, do you notice that your, his bundle, proximal even, change up a little bit of a EGM there. That fact that this is a premature bit. Okay. Now I want you to show me your ablation signal. That's even more interesting, Dr. Park raising question. Okay. Yeah. So your catheter definitely in 5-6. Go back to X-ray. Your ablation site. X-ray, please. Yes. You're inside the CS, right? Even an LAO view, very clear. So you're on the top.
Many other places, honestly.
So you're straight down to look at the area view. Your catheter straight down from his bundle. Can you see area view? And then you're right inside the CS. So I think you're pretty close to the probably exit site of leftward inferior extension. I think leftward. Probably that's what it is. That's why that potential looks almost like his bundle. Go to the ablation. Go to ablation. Signal, please. Yes. So that's your question about your second potential ablation. If you looked at it, look at the polarity of that thing and compare to the His bundle. What do you say? One is a negative, one is a positive, right? Yeah, the His bundle potential is initially is a negative, H12, but if you go to ablation 1-2, initial small potential is a positive. Okay? So that means I think it happened because your his is not in the right his bundle potential area. You should have a sharper his further distal into the annulus. Probably would be later than that potential you see. So I think this is just a recording issue. There's nothing got to do with the node. But I think it's certainly you are very close the left toward the extension. Left to the lower extension area. That's why you're recording this catheter. And then also
That's
you
what.
know, yeah, I want to tell you one more thing before you ask me. If you look at the potential, ablation potential, you got sharp one behind. There's a noise kind of thing. Can you see it? Right after the his sharp potential, his like a potential, there's a low frequency noise signal. Yes,
Yes.
that one.
Yeah.
That is the continuation of your extension. We see that time to time in children. Also, we had a case in the Myanmar. Another thing is that I think I gave you a paper, Dr. Pa. Some babies, some children's AV node congregated together only as you're growing. Some of the AV node may be scattered around a little bit residual kind of a nodal effect. So I'm just looking at that, is that possible or not? But that's just the idea. But I think this is you're recording inside the CS, very close to left inferior porous extension. That's what you're looking at it. And his bundle catheter is not right at the his. That's why I think you see artifact. Please ask a question. I'm sorry I interrupted you.
Is that the noise, or
No, it's
we
not.
discussed about the triple separated His-bond potential several months ago?
Yes, that's right.
Yeah.
That's why I had interest on. That's why I asked you.
Interesting finding was yesterday, even though my eye condition was not good, but I saw this kind of a small fractionated potential after QRS several times. It
Yes.
comes and goes. Yeah.
Yeah, right there. You see there's a bunch of us small sharp potentials, right? So I'm thinking that some patients, maybe pathology data supported that the AV node tissues may not conglomerate altogether one tissue. They may have some leftover or isolated nodal kind of tissues that behave in AV nodal region, like almost like a Maheim, atrial pathway kind of pattern. Those might be the answer of this. If you look at the paper by the Quintana Sanchez in the 2020, there is a autopsy paper suggesting that some of the AV nodes are or some of the tissue are completely isolated from main AV node, very small tissues around the nodal region. So maybe have this phenomenon that we record with this bunch of fist bundle-like potentials. So I think it is all just hypothesis we are thinking. I'm looking into the literature. I'm searching. I have a few cases like this also. So maybe interested to know to figure out what it is. But that sharp potential followed by noise or low frequency potential, that's a real. It's very consistent. I think that's where the decremental conduction tissue behaving like that.
That's why I tried many maneuvers to exclude the junctional tachycardia, because if that is the junctional initiation, but the block to the conduction to ventricular conduction, probably it could trigger the activity. Unusual finding was when I ablated the CS roof, I saw the trigger of very irregular and very fast the AV NLT-like activation sequence. So that's why I try to differentiate junctional tachycardia, but by trying the atrial pacing, eventual the diagnosis was AV node reentry.
Right. I think it's a correct diagnosis. Correct. The question is that what is the nature of this, automatic trigger automaticity and so on. And I don't think we can find unless we really know the histology and then is ultra structure of this nodal, this patient. But certainly patient very slender, long heart, young. I think it tended to have a more with this. We had, I think I told you one of your case that you did the Yonsei University and the recurrence, and then we did the Yongin case in the Yongin had a similar thing. So we have about 4 or 5 cases right now. So I think we should be looking to maybe perhaps review a little bit more. But the fact is that the his distal 1-2 initial polarity and then ablation 1-2 completely reverse. It suggests that the tissue is between two, whatever the source of the potential. But that's all hope that we can find the answer at some point. Okay? But
The
it's a very
bottom line
interesting
to the
case.
fellows education, just in case you his-bond location right, and that is true his-bond potential. If the ablation shows looks like a clear slow pathway potential, but it is later than his, don't burn it, please.
Yeah. But, there's another consideration here is like similar to this would be a twin AV node phenomenon, anterior posterior AV node. But physiology, your patient physiology does not support the twin AV node.
Yeah.
So, yeah, I
I
think
also
just,
thought I also thought about the twin AV node, but the
yeah, but it's not.
refacing did not change tachycardia.
Yes.
I
That's a
exclude
tachycardia pattern. Yeah. That's why we're looking at the EKG with 12-lead tachycardia with a different than sinus rhythm, QRS axis. That would support also twin AV node, but it doesn't. So,
Another question is in this elongated heart patient, last week you told that we need to, the ablation catheter tip should be directed downward, right?
yes,
But the
definitely.
patient with the longitudinal shaped heart, sometimes when we try clockwise rotation, but the
Yes.
actual the tissue contact at the distal electrode tip is very poor. Yesterday we could not get enough the high temperature during ablation.
Mhm. Okay.
So at the time, what is best way to make a better contact to avoid
Yeah, I
avoiding
think,
the
yeah,
avial block?
yeah. When you have this such a long elongated heart patient who has AVNRT, their CS roof tended to curve toward the AV node. So I would probably for the juniors when they start doing this, take a quick picture of a CS coronary angiography to find out what's the definition anatomy of that area. Because you may not be talking posteriorly enough. A lot of time you think you are, but you're not. The reason is that the eustachian ridge and the tendon of Todaro can make you that make it harder. So then next option that we use all the time would be SL1 sheet, try to help you torque the catheter more posteriorly based on the CS angiogram and try to go to the os of the CS. And that would be the first maneuvering. Then you have a sense of how much you have to torque it. So I think I would do probably first thing I would do if I were you, CS coronary angiography, such a hard cases to find out anatomy with that area. Then you know exactly visually how much you have to torque. Okay. Now, one thing caveat you have to hear that if you rotate a catheter clockwise, your tip gonna rise towards the his bundle. So you have to torque clockwise, same time deflection down, ablation. You got to do together. That way you can maintain same level of your target area you want to keep it. So you can think about that a little bit in anatomy. It's important. Okay.
Dr. You did the CS angiogram in patient with PSVT. Many patients.
Yeah.
So can you share your experience?
A couple of years ago, usually I performed the CS angiogram in patients with PSVT. Most of them, CS is a little bit larger in patients with AVNRT. So sometimes, especially the also the proximal coronary sinus shaped like funnel shape. So at that patient, it's difficult to maintain or maintain the catheter contact in trough area. I think the CS angiogram in patients with AVNRT is helpful, useful for maintaining the CS ablation catheter contact and stability.
So if the structure is very difficult to make a good contact, what's your next choice?
I think the 3D mapping and
3D
calculation is
wow, expensive.
helpful because we can maintain, monitor the contact force and catheter stability using 3D mapping.
Very helpful. Dr. Wang, how do you think about using the irrigative catheter for PSVT ablation?
Well, the obviously Jackman's lab and most other labs they use irrigation catheter, especially for the slow path ablation. But the concern is that, as you know, irrigation ablation lesion depth is deeper than typical standard RF resistive burn. Not knowing exactly how deep tissue endocardium toward the rightward posterior extension location, I think our experience that we had to use those irrigation very small number of patients, less than 1%. I don't use only reason that because it's a cost issue, and second is that cumbersome to irrigate the tubing and all that. Maybe that's my habit, but Sonny thinks that to make complete lesion of a posterior extension, he thinks that the recurrence rate can be reduced by using irrigation ablation, but certainly high power should not be delivered in that area. So standard irrigation ablation may be okay. That I think was the data shows. Okay.
So how much power is acceptable?
Usually they ablate for 25 watts to 35 at the most. I think in most lab use 30 watts. Standard irrigation 70 cc. Yeah,
And
that's the data from
60
J&J.
seconds?
Yeah, 50 seconds. But usually, if you don't have a junctional rhythm within 5-10 seconds, you should stop because there is not in the right spot, especially the irrigation catheter. Okay.
So when I visit the Jonathan Kaman's lab 5 years ago, they used the irrigative catheter in every single patient,
Right.
regardless the AF or PSVT.
Yeah.
So, but I didn't use that because it is expensive.
Yes.
Yeah.
I mean, efficacy, you can look at your own data to take a look at any case that you've done irrigation versus same tachycardia that you've done non-irrigated. Because certainly for the third world country, many other countries, technology is expensive, not available sometime. So I think data is clear because the last 30 plus year of SBT ablation, I don't find anything statistically significant different in my lab, but that doesn't mean is that true. So I think you might want to do internally, but also you have a lot of experience serving voluntary in work in the third world country. We use a standard ablation. We haven't really had that much trouble. So I think cost efficiency, and then there have never been any actual charring, anything like that, embolic stroke, any of those nature. So I think as long as the quality outcome is the same, maybe advice to maintain, cheapest technology that works well. And I think other issue that you got to get used to with your catheter. Certain type of catheter you like to use more to ablate, and you're very good at it. So on the other hand, you just because of new technology does not mean going to work well for you. So I think there's also operator variability as well. And the other thing that you have to think about it. In children, if you make an irrigation ablation, sometimes, you all know that the heart size grow as a scar also grow. I wonder what happened with that scar. And when I see a baby or child less than 40 pounds or something, I try to really not to use much as possible deep lesion forming ablation technology. But I don't know, Boston children changed their policy now, but I don't think they do, for the small baby. But that's something that we need to find out. Okay.
Okay. Anyway, in this patient, I tried operating the many patient inside the CS as Padma shows in fluoroscopy, but the final success side was unfortunately, usual right inferior extension, slow pathway error. Okay. Any other comments?
Yeah, your catheter pointing to the roof of CS.
Yeah, because the tachycardia was induced again and again.
Right. So that's, the pointing roof inside the CS is fine. But in the mouth of a CS, you don't want to point catheter up. Your compact node may be sitting right on top of it. Like
Dangerous.
Dr. Holmes says, because of funnel shape, You don't know how much the funnel shape outward. So that is a concern. There's early days we had some initial heart block cases because of people ablating pointing upward. So many people have wondered about us and taught us about that. Okay.
Okay, any other
All right.
question? Comments? Okay, thank you very much,
Thank you
everybody.
so much. I'll
Mark,
see you guys.
and
Okay.
so
Thank
Dr.
you.
Wang, please safe trip back to Korea.
All right. Thank you so much. Have a good day.
Bye bye. 감사합니다.